today. Uh, Celeste, say hello so you'll be on camera.
Okay, hello everyone.
Oh, great. And Celeste, the reason I wanted to interview Celeste is that she is an RN. I think she retired from the profession, and she is very active in. She's an author. She's written some really nice books. She'll tell us a bit about those. But we really want to talk about fibromyalgia today. She is a fibromyalgia sufferer and other chronic pain issues, and so she really is very knowledgeable in this still misunderstood field of fibromyalgia, particularly in more widespread of chronic pain. Welcome there, Celeste.
Thank you, Tony. Thank you for having me. I appreciate it.
Well, listen, we wanted to talk about fibromyalgia. Let's just get right down to it. What is fibromyalgia?
Fibromyalgia can be defined in 4 different ways right now. We have 4 different criteria, which we have discussed before. Pretty much the family physician, which is the first person that a patient usually goes to, is familiar with the tender point count, which is the presence of at least 11 of 18 tender points on the body of a fibromyalgia patient located in specific areas. This criteria was never meant to be what it became. It started out as part of a research study, but it grown in popularity, and in 1990 the American College of Rheumatology approved that criteria. However, it has met with some criticism because we know a whole lot more now today than we did in 1990, and we know that patients can have tender points pretty much anywhere on their body. It's not located in just those 18 points, though those still do seem to be the strongest. It's not confined to those particular points. It's body-wide pain, and I think most experts will agree that there are 3 or 4 components depending on how you look at it. Disordered sleep, which has often been solidified with sleep studies. We don't tend to get the healing stages, the slow wave healing stages of sleep, which are stages 3 and 4. We have body-wide pain, extreme tenderness, cognitive disturbances, finding words is difficult. Sometimes I have issues with that and probably will in this interview. And fatigue, overwhelming fatigue that interferes with our ability to participate in life. And probably the worst symptom for me to deal with as an author and a writer is the fact that it's so unpredictable.
You can have good days and bad days.
Yes. And when we have good days, and this is pretty typical for most fibromyalgia patients, when we do have good days, we tend to overdo. And then for some reason, and there's research to suggest that fibromyalgia is an immune system disorder. There's also research to suggest it affects the central nervous system, in particular the sympathetic and the autonomic nervous systems. And so it's not unusual that we have a delayed response. As a matter of fact, I think that delayed response to the overactivity is really typical of fibromyalgia.
So you told us what the primary symptoms are. How does a doctor go about diagnosing fibromyalgia then?
They should do a hands-on assessment of your pain. Pain is generally the primary symptom that sends the patient to the doctor to say, hey, you know, what's going on with me? The doctor may rule out other things such as lupus or MS, those types of things, which tend to have symptoms that are very familiar to fibromyalgia. So they may rule those out, even though we do have diagnostic criteria. Most physicians, being family practitioners, don't have a lot of time to spend reading all the journals and things that I do as an advocate. And so they do what they're most familiar with, which right now is the tender point count. Doing the exam and how you do the exam is extremely important, because we believe that there needs to be enough pressure to make the examiner's fingernail blanch. So you can't just give a light touch, though we are very sensitive to light touch. To actually do the physical exam, the examiner should put their hands on the patient and examine them for tenderness. The other things that they should consider are things that have been clustering with fibromyalgia, such as the coexistence of particular disorders that have been defined by the National Institute of Health and the CDC, and they're listed on their website, and those are rheumatoid arthritis, ankylosing spondylosis, and systemic lupus erythematosus. Those seem to be the three that the NIH and the CDC both believe occur more frequently with fibromyalgia, or vice versa. We also know that fibromyalgia patients tend to have sinus issues, migraine, bladder difficulty, definitely irritable bowel syndrome, TMJ, some other things that can be attributed to myofascial pain syndrome, which is a muscle disorder that affects most chronic pain patients, not just fibromyalgia patients.
How would you, that's a great lead in, how would you distinguish between fibromyalgia and myofascial pain syndrome, which I've seen diagnosed also many, many times?
Right. Myofascial pain syndrome is a shortening of the muscle fiber, and we're not sure why it occurs, but we do know that there's an excessive release of a neurotransmitter, which is a chemical that provides a feedback between the brain and the body. And there's an excessive release where the nerve actually joins with the muscle. So we know what occurs, we just don't know why it occurs. But when this does occur, it shortens the muscle, which makes that muscle fiber that's affected with what we call a trigger point, different than a tender point, but a trigger point, which is shortened. Say the muscle is like this long. What happens when you have a myofascial trigger point is that muscle is then shortened because of the knot that occurs within the muscle fiber itself. Now, this can only be addressed with some type of physical involvement, such as pressure therapy, self-therapy, particular massage type therapies like active release therapy or myofascial release therapy, or trigger point injections. Myofascial pain doctors that understand how myofascial pain syndrome works understands that it's necessary to use ultrasound guided trigger point injections so that they can get into the belly of the trigger point and actually get it released. What happens then is the muscle then returns to its normal resting length and it becomes functional again.
Well, if I was a doctor, what would I do to make that determination? Is it a clinical exam that they can feel the difference between a myofascial pain syndrome and fibromyalgia?
That's a very good question, because it takes a trained examiner. I'm trained because I've done so much exploring of my own body, which I think every patient should do, no matter what their issues are. You should know your body better than your doctor does, actually. And you can feel these trigger points. They're little knotted up pieces of muscle fiber. If they're located in the face, they may be very, very tiny, maybe the size of a a pin. What do I want to say? Like a like you would use for sewing clothes together.
Okay.
And I'm having a hard time finding that word. I know I should know it, but it's escaping me right now. So it would be that tiny, but you have to remember that the muscles on the face are very, very tiny for a reason. They give us expression and so on and so forth, just like the muscles in our fingers. Now, when you're talking about larger muscle groups, such as the shoulder, the neck, the upper back, the buttocks area, the entire body actually, any place there's a muscle, you can be affected. Then, of course, the trigger points are larger. They're more like the size of a pea. You
Okay.
can see this on an ultrasound. The pain specialists that understand this type of disorder know exactly what they look like when they look at it from an ultrasound standpoint.
So you
They're
can,
visible. It's objective.
okay, you can use an ultrasound to diagnose that because you will see these, I'm going to call them little pea-like structures or a little smaller, and contrasted with fibromyalgia where you don't have those nodule-like substances. It's more of you're just pressing into the patient's body and you don't feel anything, but when you do that, if you do it hard enough to have the fingernails blanch, as you mentioned, on a wide spectrum basis over the entire body, they will have a lot of complaints when you do that it really hurts them. Am I
Right.
sort of getting that in a layman's way?
No, yeah, you are exactly. You know, I'm a patient that has both, and it was difficult for me to understand initially. It takes a lot of studying and a lot of like I said, getting to know your body to really define the difference. It is the way I explain it for myself is that fibromyalgia is the tenderness. I feel like my body is one big bruise. My clothing, if it's too tight, it's just not uncomfortable. It hurts. Myofascial pain syndrome, on the other hand, I can be rubbing around on my shoulder or in my neck area, and I can feel these little pea sizes, and when I push on them, they radiate pain, and they radiate pain in a specific pattern. And this is what the specialists that specialize in this know. Most doctors, including rheumatologists, do not understand the difference. They're not trained in it. They don't get any training. If they do, it's very little into the myofascia. And most experts that deal with pain would agree that chronic pain issues are more likely to be myofascial related than they are to be joint related or spinal related. The spinal pain that we experience is because of the dysfunction of the muscles or the discs involved that put pressure on the nerve roots.
Okay, and one of the notes here that I have about the diagnostics is this FMA blood test used by NIH. Could you talk about that briefly?
Sure. I am a big supporter of the National Fibromyalgia and Chronic Pain Association. They do a lot of work in networking with the CDC, the NIH, with pain consortiums, and they are involved in the PAINS project along with myself. And they attended an NIH meeting where NIH did say they were going to use the FMA test that was developed by Epigenics in response to a study that was led by Dr. Beam to make sure that the participants in the study did in fact have biological fibromyalgia.
And so there's a way to determine this by blood testing?
Yes. And
Does everybody that has fibromyalgia have a positive blood test for it?
it was 93% when they did a follow-up study, and I had talked with Dr. Bruce Willis, who led this whole epigenetics and development of the FMA test, and some insurance companies will reimburse for it, others will not. So far, Medicare has not approved it. I expect that it will be in the future, because what happened was with the initial study is that the naysayers wanted to say that you didn't compare this to other like autoimmune diseases such as lupus or RA or ankylosing spondylosis, the other rheumatological autoimmune disorders. You didn't say that you related this to these other conditions. So how do we know that this is specific to fibromyalgia? So they went back and they have done the study, and the study has been shown to be 93% effective in defining fibromyalgia patients from these other rheumatological autoimmune disorders.
And what's the name of the blood test again?
It's FM/A and then test.
And what doctors would know how to order that? If I believe I'm suffering from fibromyalgia, and I'd really like to know with some specificity, would it be a rheumatologist?
Most rheumatologists should know about it. This is so fresh, this repeated study, this follow-up study that found this has not even been published in the papers yet. So I would not expect all doctors, even all rheumatologists, to understand that it's going to be available to them.
And who's the author of the study?
The author of the first study is Dr. Behm, B-E-H-M, and I'm going to have to fiend. If you give me a minute to look it up, I can find you the author of the other. However, you can follow my blog because it will be on there. I'm writing a blog that's going to be posted on the 31st of this month, and I did post a blog at the beginning of the month. Actually, you could probably find it there. I try whenever I can to list the resources when I think that they're important.
What is the link to your blog? What's the address?
It's FMCFS tender trigger points, .blogspot.com. You can also access all of my networks directly from my website, which is these3.com, spelt out TheseThree.com.
These3.com. What are the
That's right.
So what are these three, Celeste? They got to stand for something.
Well, originally it started that it was going to be fibromyalgia, chronic fatigue syndrome, and myofascial pain syndrome, which is what we address in the big book that was published by Healing Arts Press. And since my life has taken on a new direction in the chronic pain world and in my advocacy there, it's now more about myself as a patient, an author, and an advocate. So you can apply it either way.
All right, great. Well, we'll go to that website definitely, Celeste. Let's talk about what people can do if they have fibromyalgia to help themselves and their quality of life. I've seen people, Celeste, in my practice with doing Social Security work, of a broad spectrum of some people could work, some people could work a little bit, and some people could really not work much at all. And so we used to have a wonderful doctor here, Dr. Emily Hess, who was our local expert on fibromyalgia, and she used to discuss people to get in support groups. But you know, you tell us: is there diet? Is there exercise? What works?
Well, as far as severity is concerned, I think that kind of relates to how many of the comorbid conditions a patient has. It's like a add-on effect. Of course, the more you have, the more triggers you're going to have to your fibromyalgia pain. So that has to do with the severity of it. You're absolutely right. Some people are able to remain in the workforce, and I'm very glad for that. Some people are discriminated against in the workforce for having fibromyalgia, which is very sad as well. But what can you do to manage? Whether we have a biomarker, whether we have a blood test to diagnose fibromyalgia, that's just the first step. Because just like MS or any other autoimmune disorder or lupus, any of those, they all have biomarkers, but people still are struggling because we don't have a cure. So what can you do in the meantime? You can read self-help books like those that my co-author and I have authored. An important aspect is to understand that pain is not related just to the physical. Our mind does believe and our body does believe everything that we say. So, garbage in, garbage out. Change the way we talk to our body, change the way we talk about ourselves in relationship to our body parts, using mindfulness techniques, using psychotherapy if it's necessary. Before I was even diagnosed, I didn't know what was wrong with me, and I thought, well, maybe it is all in my head. So I saw a therapist, and he assured me that no, I did not have a mental illness. But and having your pain validated, having somebody tell you that this is what's going on, is a big deal. And keeping to a good sleep hygiene, even though we know that it's not going to change the way the body reacts, it's not going to change the results of your sleep study, but it is going to change the way you deal with letting down at night. Don't be watching TV in bed. Pretty much the common sense things that most doctors will tell you for coping. There is no specific diet, as much as people would like for you to believe that. There is no diet to cure it. There could be an acid-base balance issue. Pretty much the best way to determine that is on an individual basis, because we're all different. What might work for me might not work for another fibromyalgia patient. So I'm not saying you shouldn't evaluate your diet, but you need to do it with a very concise program that's individually based, so that you know what you eat when your symptoms come up, so that you can make a relationship between what you're eating and how you're feeling. Too much sugar is a big no-no.
Yeah.
And that's true for anybody.
That's true for all of us. And my oatmeal in the morning, I try to put a little bit of brown sugar on it at the most. Celeste, what about pain management and narcotic medications? What's your feeling about that?
Well, my personal thoughts are that whatever it takes to help a patient feel better is what they need. If that includes opioids, medical marijuana, some people are having some good results with the FDA-approved drugs. However, it's a very, very poor response in comparison to some other things. I think that what we need to always think about when we think about medications and therapies, whatever you decide to do, is to improve function. If it does not improve your function, then it's not the right thing for you to do.
And I don't know if you can answer this one, but this is big in my mind and all over with the chronic pain. How much medicine is too much? I mean, a person comes into the doctor's office, the doctor believes them, they've had a good work history all their life, and they're just saying, I'm in pain, I can't function, and they might start them off on some hydrocone or something, but I see them get stepped up to Dilaudid, and is there a point where it's too much? I mean, or is that just a judgment call between the patient and the doctor?
definitely is a judgment call between the patient and the doctor. Again, here we go back to function. If the person is not able to stay awake because of their medications, whether it be not necessarily just opioids, but it can also include the anti-seizure medications and the antidepressants, they can have the same type of effect. And if you're getting too much of it, then you're not able to function. So, in my opinion, the first question that a doctor should ask their patient is, how is this medication, whatever it is, or therapy, improving your function? If they can say, I'm still in a horrible amount of pain, then and they're already topped out. I mean, our body does learn to tolerate drugs. Our body learns to tolerate the antidepressants and the antipsychotic medication. I mean, our body learns to tolerate a lot of things. We're not supposed to stop any of our medications abruptly without first consulting with our doctor. So we do develop a tolerance, and you might have to be stepped up in order to get pain relief. But for that particular patient, it's between the doctor and the patient. Obviously, if the doctor finds the patient is falling asleep while he's trying to do an interview and is touching the patient and they're not wincing or withdrawing or showing any outward signs that they're having a lot of pain, they may be over medicated.
And that can be a big problem. You know, Celeste, I was very lucky. I had there was a point in my life where I was getting these chronic headaches, and I had I had a surgeon go into every sinus in my. He said, you got sinus headaches. He went into every sinus, and it's about $1,000 a sinus, and I think on each side you have 18 sinuses. My headaches were worse. He said, I don't think I got into this one real good, and this one I think closed back up. I go in another surgery. I'm still bad, if not worse. He says, you know, let me take you over to the university. They got a better machine. Finally, I said, no, I don't think this is working. And I was so lucky to find another ear, nose, and throat doctor who was, I would call him an amateur psychologist, and he was very well read, and he basically said, you don't have sinus headaches, you're stressed out. He prescribed, I'm going to say it, maybe it'll help somebody, I'm not ashamed of it, amitriptyline, very low dose, and clonazepam, very low dose.
Right.
Didn't give me any type of buzz, high, or anything. And within a month, my headaches were gone. And so it just shows you, I guess the other thing I guess you would say and I would say is, hey, if you're trying a doctor and you're not getting any better and any relief, maybe you go on to the next guy. Who do you suggest? You know, like you said, the family doctor, he's not reading and staying up on this. He just doesn't have time. Would you suggest a rheumatologist or someone else, or a pain management doctor? What's your sense there?
My feeling is that fibromyalgia patients need a team of doctors, not just one. And the reason that I say that is because, like I said before, not all rheumatologists understand myofascial pain syndrome. An educated pain doctor that specializes in multiple ultrasound-guided trigger point injections will know about myofascial pain syndrome without a doubt. So if you're not getting good relief with your rheumatologist, it doesn't mean he's a bad rheumatologist. It may mean, it could, but it may not necessarily mean that. It may just mean that you need to add another person to your team.
Okay,
Sure,
in terms of a pain doctor, they can have a background from various different fields of medicine, right? I mean,
That's right.
anesthesiology, I know. Uh, is there any particular field that you like to see them coming out of?
First of all, a sports medicine doctor, which is not necessarily a pain doctor, understands the kinetic movement of the body and how everything interrelates, and they do understand. I haven't met one yet that didn't understand myofascial disorders. However, as far as pain management doctors go, I've seen both physical rehabilitation doctors, physiatrists is what they're called, and anesthesiologists who do understand myofascial pain syndrome, and I've seen an equal amount who don't. Uh, I think it's important that the pain doctor does understand both fibromyalgia and myofascial pain syndrome because there is such a strong comorbidity between those two. And you have to be very careful. It's a fine line that's walked when you have fibromyalgia and myofascial pain syndrome, because some of the therapies used for myofascial pain syndrome can send a fibromyalgia patient into an extreme flare where they can't even hardly bear to sit because of the pain. Because what happens is during myofascial therapy, toxins are released from that muscle that's been holding on. It's been grabbing a hold of all of those toxins that build up in the muscle tissue itself, that weightlifters understand for sure. When you go for physical therapy, they'll always tell you drink lots of water, and that's to flush those toxins out. And what happens to the fibromyalgia patient, we're extremely sensitive to those types of things. And so we might not only just feel kind of yucky for a couple of days, we may be throwing up. So it's important that that whoever you decide to go to, that number one, my first question always is, when I call a pain doctor, and I found a great one in Arizona and just recently found somebody that I have yet to see here in Kansas City, is, does this doctor do multiple ultrasound guided trigger point injections? And do they use steroids? Because if they use steroids, that's not the doctor you want to see. Dry needling is important. Lidocaine, there are biotanical, which is plant-based anti-inflammatories that you can use in excess and be okay. It's not okay to inject 30 trigger points with some type of a steroid. That's not healthy for the patient, nor does it serve any purpose. We know that myofascial pain syndrome patients do not respond well to steroid injections because they're limited. The doctor can only give you a few. And if you don't get the primary trigger point, the patient's going to leave there thinking that they had no success to their treatment.
Okay. Well, Celeste, we've covered a wide range here, and it's been really, really informative and very good. I'd like to just talk to us briefly, just a little bit, toot your own horn, and I tooted for you, but I haven't had a chance to really get into your books, your authorship, some of your main books that you think can help people, educate people, help them have a better quality of life. What would those be if I want to go on Amazon and
Okay.
partake? Oh,
If you have fibromyalgia, chronic fatigue syndrome, and suspect you may have myofascial pain syndrome after our visit here, I would recommend our book, Integrative Therapies for Fibromyalgia, Chronic Fatigue Syndrome, and Myofascial Pain, The Mind-Body Connection. It's published by Healing Arts Press, and it's very specific. There are a lot of guides to help the patient decide which, if they have all three. Some patients do. Some patients don't. They may only have one thing. But it will help the patient decide, this is the category I fall in, or this may be my more predominant problem. And we talk a lot about exercise physiology and when and why and how. Fibromyalgia patients need to always start low and go slow, whether it be medications, therapies, or exercise. Myofascial pain syndrome patients should not be doing yoga and holding postures when their muscles are short and tightened, because what that does is put an extra stress load on the other muscles that are trying to make up for the deficit created by that shortened piece of muscle. And it also addresses the mind-body issues, and as I told you before, there's a chapter on navigating the red tape that's associated with those disorders. If you're a chronic pain patient in general, we have the Broken Body, Wounded Spirit series, and it's a series of 4 that's based on each season. And they are daily devotionals for the patient to interact with the book. A lot of inspirational quotes to help people stay motivated and positively minded in spite of living with chronic pain.
Celeste, have you ever tried a Healing Hands treatment where they work with the energy?
I have actually had some Reiki. For me, it didn't work, but that doesn't mean it doesn't work for other people. I do believe in the healing power of touch. I'm a nurse, so I often would pray and touch. I always touched my patients. I mean, I wouldn't grope them, but just let them know that there was a person standing beside them that cares about them. And I think that the power of touch is remarkable and can help many people. A lot of people they never get that. They never get a hug, and we talk about that in our Broken Body, Wounded Spirit series about hugging and not invading somebody else's personal space, being cognizant that that does exist, but also being aware that there are people who need to be hugged. They need to give hugs and receive hugs.
And I know some good friends that if you go hug them, they give you a shoulder block because they're just a little, they're just
they got a learning curve.
That touch, and they're a little bit uncomfortable, and that's okay.
And that's okay. You just need to ask first.
It took me a long time to be able to. Well, I hug my clients sometimes. I just it's not awkward. You just feel it's a comfortable thing to give somebody a hug and give them support. They say pain shared is pain lessened, and there's a lot of healing in just a good hug. Well, Celeste, I've really enjoyed talking with you, and I've learned quite a bit. I'm not going to go back and backtrack. We've talked enough. We didn't really get into the causes of it, but I don't think that's really our issue right now. It's, do you know you have it? What do you have? And what can you do about it? And I think you've really covered the ground on that wonderfully. I really appreciate you taking your time here to speak with me. And so give us your blog one more time so we can all go there and follow what we need to follow.
Well, I hope I'm saying it right. Remember, I have short-term memory issues.
Okay.
But I do believe it's fmcfstriggerpoints.blogspot.com. If that fails, you can always go to my website, these3.com, and there will be a link to my blog.
That's simple enough. These3.com. That I like the best, Celeste.
Okay.
All right. Well, Celeste Cooper, author, RN, chronic pain management sufferer, advocate. We'll see you around, and it was really my privilege and honor to have you come and speak with me, and I will certainly share this video and put it out on one of my blog posts. I'll ping you and we'll get this out because I think it was really really helpful.
Well, I have to say this to you. I wish more attorneys in your position would thirst for the knowledge for their clients that you do. You're remarkable, and I appreciate it.
Well, thank you, Celeste.
Mhm.
I appreciate you saying that. So, listen,
bet.
you have a great day, and we'll see you around.
Oh, yes.
All right. Bye
All
now.
right. Bye-bye.